Good morning. Welcome, everyone, to our first thyroid tumor live Facebook discussion. I'd like to start briefly by introducing myself. My name, again, is Mabel Ryder. I am a consultant here at Mayo Clinic. I've been here for about 4 years, and I was recruited from Memorial Sloan Kettering Cancer Center, where I had been worked previously with a focus for 7 years on endocrine cancers, specifically thyroid. At Mayo, I specialize in both benign and malignant thyroid disorders, and uniquely, I have a joint appointment in medical oncology where I also specialize in advanced cancers, endocrine cancers, the majority of which are thyroid. We see a wide scope and depth of thyroid disease here, particularly thyroid cancer, and a broad spectrum of both very low risk, intermediate risk, as well as advanced thyroid cancer patients. For our discussion today, I'm joined by my colleague, Dr. Travis McKenzie, within the Division of Surgery, and I'd like to have Travis introduce himself and tell us a little bit about his specialty and interest in thyroid.
So my name is Travis McKenzie. I'm an endocrine surgeon, and I work very closely with Dr. Ryder. I have expertise in thyroid, parathyroid, adrenal, and pancreas surgery. And a large volume of my practice is actually thyroid surgery and operating on a thyroid cancer.
So I thought for our viewers, before we talk a little bit more in detail about our approach to thyroid nodules and our surgical approach to thyroid cancers, I'd give everyone, or we would give everyone, a brief scope of our practice to get a sense of what we see and what our volume is. So I think the most important thing that has given myself and surgeons like Dr. McKenzie expertise is that we have a very high thyroid nodule practice, where between our thyroid nodule clinic, our thyroid clinical practice and radiology, we see over 1,000 patients annually with thyroid nodules, and many of which ultimately are selected for fine needle aspiration or biopsy. We're benefited by very high resolution comprehensive neck ultrasounds that we review with our expert radiologists together with us as endocrinologists and with our surgeons to really assess these nodules and whether we need to biopsy them. When we do select certain patients or nodules for biopsy, more importantly, our biopsy results when completed are the results are often available within hours for our patients. And I think this is really unprecedented, Travis, in our practice, that patients, especially traveling from a long distance, coming for evaluation of thyroid nodules, we can biopsy that nodule and get the results within hours.
That's right. And things happen very quickly here. And one of the advantages of that is when you're seeing a patient and they get a thyroid nodule biopsy, they can see the surgeon for surgical planning the same day,
Right.
so things happen very quickly.
In addition to our fine needle aspiration turnaround, what's important is we have expert cytopathologists who are interpreting our FNA slides. And I can't emphasize the importance of this enough, in that our cytopathologists are really world's experts in thyroid and thyroid pathology of thyroid nodules and thyroid cancer. And this means that many of our biopsy results have definitive results in at least 90% of cases, and only 10% of cases is sometimes surgery required to determine whether there's cancer or no cancer. Next, of course, as I've introduced Dr. McKenzie, and the reason I invited him to join us is that surgeons are a very important part of our practice, and importantly, surgeons with a really high volume practice of thyroidectomies.
We have a team of 4 endocrine surgeons here at the Mayo Clinic in Rochester, and all of which are high-volume endocrine surgeons, which has implications, and we'll talk more about the risks of thyroid surgery, but it has very strong implications with regard to the risks with surgery, meaning the higher volume surgeon you are, the less chance of something bad happening during or after surgery. And we certainly see a very large volume of thyroid cases here, and really complex cases too, which plays into the expertise here.
Right. And I think one thing that, Travis, you and I really enjoy about our practice is that when a patient needs thyroidectomy, and when we consult with you all, our expert surgeons, we see the patients together. So you come up to our clinic, our floors, we discuss the patients together, you see them, we go in and see them, and so the patient is really getting a nice multidisciplinary approach in real time.
And this is really the true quintessential multidisciplinary approach, in that we're evaluating the patients beforehand together, looking at images together, and then we see the patient together. The patient isn't seeing different providers at different places at different times. this all happens together, and all these great minds are functioning together to decide what to do, what's best for the patient.
Yeah. And we also have a very skilled set of interventional radiologists when sometimes surgery may not be the best approach or there's an alternative to surgery. We have interventional radiologists where we can sometimes consider approaches such as alcohol ablation for different thyroid disorders. And then lastly, over the last 9 months, we've established a very multidisciplinary comprehensive thyroid tumor board, which you and I really enjoy and learn something from every meeting because we discuss both simple as well as complex cases and we get opinions from a wide group of experts in the room on real-time management often. Yeah. So I think we'll after this brief introduction and as questions will start to filter through, I think it's important to start the discussion on thyroid nodules because these are extremely common and our approach has importantly evolved and improved, I would say, over the last several years. And so we at Mayo Clinic in the last few years developed, in collaboration with our Mayo Clinic enterprise in Arizona and Jacksonville, as well as within the Mayo Clinic Health Network, developed an Ask the Mayo Expert algorithm for assessing and evaluating and managing thyroid nodules. And this tool then will help the primary providers and patients who perhaps see less frequently thyroid nodules and where to get started. This algorithm was timely, Travis, because as you know, the American Thyroid Association also last year published their updated guidelines on approaches to thyroid nodules and thyroid cancer. And maybe we'll get into a little bit of that, but what do you think about the new guidelines and how overall it's impacted your practice?
There are some very important changes with the new guidelines that affect how we work up nodules in regards to which nodules we biopsy, and size plays a big criteria in that. And in addition, in my practice, the new guidelines have suggestion of thyroid lobectomy, meaning taking out half of the thyroid versus the entire thyroid based on the size. So there's sort of a more liberal approach in regards to what you can do for a nodule that's 1 to 4 centimeters. Do you have to take out the entire thing, or can you just get away with taking out half of the thyroid?
Yeah, I think that's very important, and so we'll certainly come back to that then as we proceed. So one of the first things I talk with patients about when I see them in the office is that nodules are common within the general population. So if you sample 100 patients that come to Mayo Clinic, I tell my patients that 70 out of those 100 patients, or 70%, will have thyroid nodules. And I don't know that all patients understand that. So it's a very common diagnosis and a very common problem. And most often, Travis, these are diagnosed incidentally.
They are.
Yeah.
Images are done for a lot of reasons nowadays, whether those be ultrasounds, CT scans, MRIs, PET scans, and these nodules are picked up.
Yeah, and most often I think patients have no symptoms of these nodules because they're often small, and if it wasn't for that incidental either CT scan in the emergency room or for other reasons, they would have not known they had nodules. Mm-hmm. And that does factor into our clinical assessment and approach ultimately for patients. And one of the questions that's already coming through, which is going to lead into our discussion, is with all these nodules that are common, 70% of the population, should all nodules be biopsied, or is an ultrasound sufficient for some without a biopsy? Very important question. And so this leads into our discussion about, since there's a sea of nodules, 70% of the population has them, which ones are cancer? And in our general population and in national databases, only 5% of all these nodules are cancer. Mm-hmm. So we have a sea of benign nodules or not cancer, and we have to somehow identify of those nodules which 5% are cancer, which do we need to biopsy, mm-hmm. and which potentially do we not need to biopsy. So we rely very heavily on clinical symptoms and features, and as well ultrasound. So ultrasound features really are our gold standard in evaluating thyroid nodules. And there's specific ultrasound features that we look at that helps us stratify whether a nodule is likely benign, for which we don't need to biopsy, or whether a nodule is low suspicion, in which case small ones we may just watch, or larger ones we may biopsy, or whether the nodule is clearly suspicious, and if it meets a certain size threshold of 1 centimeter or greater, we would routinely recommend biopsy. So Travis, can you talk a little bit about the ultrasound features that you pay attention to, or that we in the literature know are associated with thyroid cancer?
Sure. So certainly size is a very important one, and based on the new ATA guidelines that we discussed, small nodules don't necessarily need to be biopsied in most cases. And by small, I mean usually less than a centimeter. Nodules that are larger are more suspicious, all things being equal. I look for things like the echogenicity, which is a term roughly for density. We can tell that based on ultrasound. But a hypoechoic nodule, as we call it, is more suspicious. Mm-hmm. Certainly we look at the borders of a nodule. It's very smooth and rounded. That's less concerning. If it's heterogeneous or lumpy bumpy, so to speak, that's more concerning to me. And then we also look at the lymph nodes, and we're going to discuss that as well.
Yeah. So on ultrasound features, and in our AME, or Ask the Mayo Expert algorithm, we developed a scorecard with the assistance and expertise of Dr. Maitreyi Patel in Arizona, who really broke down many of the ultrasound features into something that we can quantify and add up points. And so that the points relate to, is the nodule solid or cystic? So a purely cystic nodule is really less than 1% risk of cancer, and most of those don't need biopsy. A nodule that's mostly cystic and has a little bit of a solid component, most of those are also benign or not cancer. A nodule that's entirely solid, so it's a ball of cells with very little fluid, that could be benign or cancer. We then look, as Travis said, at the echogenicity, how bright or dark it is on ultrasound. And the darker the nodule is on ultrasound of a solid nodule, the more it's a suspicious finding. The borders are very important, and irregular borders are suspicious. We look at microcalcifications, which is a very helpful feature on very good high-resolution ultrasounds. And if there are tiny dots of calcium in a solid nodule, that gets a point because it's a suspicious finding. And then there's things like taller than wide, which is just a specific unique category. And altogether, if you add up the scores for a very dark or hypoechoic nodule with irregular margins with microcalcifications, the risk of cancer for that nodule is greater than 80%. And if that nodule then is a centimeter or larger, we think it's appropriate to biopsy that nodule. If it's less than a centimeter, even if it's suspicious, as data we may get to talk about, most often, even if a cancer but less than a centimeter, they're often benign behaving. And that's data based on here from the Mayo Clinic as well as from Japan.
And I'll point out with ultrasound, from the patient's perspective, it's a relatively easy thing to go through in regards to there's no radiation, so there's a very low risk with that.
Are you talking
it's
about
non-invasive,
the
ultrasound itself. And it's a non-invasive test, and it gives us a lot of information as the endocrinologist or the surgeon going forward.
Right. So benign features of nodules are nodules that are brighter on ultrasound, so brighter than the normal thyroid. We call that hyperechoic. And nodules that are very regular, again, fluid-filled, tend to be low suspicion. So we use the ultrasound features, and then we use size to determine which nodules to biopsy. The olden days used to sort of be, let's biopsy everything, any nodule. And we've really moved away from that because, again, we know very well that most nodules are not cancer. And even though a biopsy is fairly straightforward, and in 20 minutes we can have it done, and in a few hours we can have the answer, I think it's not the best approach. I think a risk-based approach, determining which nodules really should be biopsied and which could be followed on yearly ultrasounds or every few years, is a better way to go. And it subjects patients through those patients with perhaps suspicious or larger nodules are the ones to biopsy. Other patients with incidental, non-symptomatic nodules that looks low suspicion could just be followed. So once we decide to do fine needle aspiration, the standard of care is to do ultrasound-guided biopsies. And this is really important, and I think it's done nationally now. In the olden days, it used to be you palpate and feel where the nodule is and put a needle in. Now, because most of the nodules we identify are incidentally found, in most patients we can't feel them, ultrasound guidance is really important to target precisely that nodule. And here in Rochester, we have a thyroid nodule clinic where we do the biopsies as well as it's done by radiology. And really what's important, again, is our cytopathologists. Our reviewing thyroid nodule FNA specimens I think there's an art to this. It's not so easy.
Absolutely.
You have to make sure there's enough follicular cells present on the slide to even make a diagnosis. And then you have to really have a depth of experience in looking at thousands of these and knowing what the outcomes are to really get a sense of which nodules are clearly benign, which nodules are clearly cancer. And for those indeterminates, where you can sometimes have what we call funny-looking cells on the slide, it really takes an expert cytopathologist to classify that definitively as either not cancer or suspicious for cancer. And so nationally, cytopathology is used to classify thyroid nodules, and often it's the Bethesda classification scheme that's used. This is a category of 6 different FNA categories where FNA results fall into, and this is either number 1, the FNA is non-diagnostic, which means there's just not enough cells there to make a diagnosis of benign or cancer. And interestingly, in our data set at Mayo Clinic by Dr. Moria Stan in our division showed that of those that we get that are non-diagnostic, which is fortunately very few, those that do get rebiopsied or go on to surgery to get a definitive result are mostly benign. So that's reassuring. But if a FNA is non-diagnostic, that means there were not enough cells for the cytopathologist to view that, and we would recommend a repeat biopsy. The other category besides non-diagnostic is benign. And fortunately, that's where most of our biopsies fall, right? So these are cells, FNAs, that have plenty of follicular cells on it, and none of those follicular cells, or the majority, do not have suspicious findings. And it's important to note that most of the diagnoses that we make of papillary thyroid cancer, you can make that by the appearance of the cell under the microscope. And in our practice, Travis, we have a really good false negative rate with our cytopathologists, right? So what does that mean to you as a surgeon?
As far as the false negative rate?
Yeah, so when we get a benign FNA, even, let's say it's a larger nodule, 3 or 4 centimeters, or it's smaller, but it has some suspicious features, but our FNA says benign.
So the false negative rate being low would suggest that if it says benign, it's very likely to be benign. And unless there's another indication to operate, like the patient's having symptoms because the big nodule is compressing on the esophagus or the trachea, really that doesn't need to be taken out because it's very, very unlikely to be a cancer.
A cancer, yeah. So I think, again, I reassure patients, and we're very comfortable in reassuring patients when we do get a nodule that's biopsied and the cytopathologists say it's benign. In our practice here in Rochester, our false negative rate is less than 1%. Nationally, it's 5% or less, and we're slightly even better at Mayo.
And I think that's a big advantage. Some institutions with a, let's say, 3 centimeter nodule, 3.5 centimeter nodule, with a benign biopsy, they'll still recommend taking it out because they're concerned about a false negative.
Yeah.
That generally doesn't happen here.
Right. And I do see patients with large nodules that on biopsy are benign and a patient's having no symptoms. And they ask me, Dr. Ryder, do you think I really need to have this out? Maybe my surgeon at home or my doctors at home say, oh, that must come out. And maybe in 10, 20 years ago, we used to do that. But I think our practice has taught us that while it may grow over time and it may cause you symptoms, if you're not having any symptoms now, you and I would feel comfortable with saying you can watch that.
Very comfortable, particularly related to the expertise of our pathologists making the call of benign. Yeah. When they say benign, it's going to be benign.
Sure. So 10% of our FNAs do fall within what we call an indeterminate category, where the fine needle aspiration is often called follicular neoplasm or suspicious for follicular neoplasm, or the other category is suspicious for Hürthle cell neoplasm. So neoplasm means a tumor, and we don't know whether that is a benign tumor or like an adenoma, or whether that is a cancer. And what defines these categories as tumor is really invasion of the tumor through the capsule and invasion of the tumor into the blood vessel. And so that's why we call these 10% indeterminate, which means that on just fine needle aspiration, where we pull out individual cells, we don't have enough information, or the cytopathologists don't have enough information to say, is this cancer or not? And the standard of care has been, in our practice, to refer these patients for what we call a diagnostic lobectomy. It means we have to go to surgery to prove whether it's cancer or not. And in our practice, the majority do end up being benign, not cancer, but about 12 to 15% are cancer, higher than the overall all comers for thyroid nodules. So surgery is important. Fortunately, in our practice, because of our expert set of pathologists, only 10% roughly of all our FNAs done annually fall in this indeterminate category. As compared to nationally and non-expert centers, as high as 30% of FNAs may fall in indeterminate categories. There's a category called atypia that most of our pathologists never use other than once or twice a year. And when they use the category atypia, generally it is something that's very an unusual tumor.
Right. And I'd like to point out a big difference with our practice here at the Mayo Clinic from the surgical perspective is when we have a biopsy, an FNA, that suggests something is a follicular neoplasm or a Hürthle cell neoplasm within that indeterminate category, something we can do here is we can take the patient to surgery, take out half of the thyroid, not the entire thyroid, but half of the thyroid. And at the time of surgery, when a patient's actually asleep, we can very accurately make a diagnosis if that is a cancer or not. Most other institutions can't do that. What they do is they take out half of the thyroid. Patient wakes up and goes home. They find out what the result is about a week later. And if it's cancer, they have to go back to the operating room in many cases to take out the other half of the thyroid. That turns one operation into two operations. So that's a big advantage in regards to what we do here.
And so again, Travis, so when you take the patients to surgery here, you're able to do this because while the patient is still on the OR and you haven't closed yet, we have pathology in the background doing intraoperative frozen review.
Yeah,
correct?
it's fantastic. So literally the pathology lab is directly across the hall from my operating room. So we take half of the thyroid over to the pathologist. They have a team of pathologists and technicians that look at the entire thyroid that we've taken out and the entire capsule of that nodule to determine if there's any invasion there. And so they can, again, very accurately say this is a cancer or not a cancer. That helps us decide what to do with the other half of the thyroid during surgery.
Right. So I think most centers don't offer intraoperative frozen review,
right.
and I think that does help the scope of the surgery. It is true that today there's some patients may not need completion thyroidectomy, even if it is cancer, but it's nice to know all of your options immediately at that one time point. And often you would have discussions with the patient before surgery. If we do find cancer, are you more inclined to have the total removed or half the still, and be okay with half the lobe removed as well?
Right. We do discuss that up front before proceeding to the operating room, so we have a plan in place regardless of what we find during surgery.
Sure. And then the final two categories of FNA results using the Bethesda system are either suspicious for papillary thyroid cancer or positive for papillary thyroid cancer. And when we get either of these results, suspicious or positive for, it's really greater than 75 to 80% chance that it's thyroid cancer. And there's very few, I think, that I've seen in my last 4 years here that have been called thyroid cancer and were not cancer.
Right.
So we have a, and I think nationally, that's fairly standard. I think most pathologists in many centers making a diagnosis of papillary thyroid cancer is fairly straightforward. Occasionally, we do get a lot of second opinions, patients who have had a diagnosis of thyroid cancer, and they may be coming to Mayo either for a second opinion, what kind of surgery do we need, or do I need surgery? And we always, our first step is to always request slides. We request the outside pathology slides reviewed here by our pathologist to confirm the diagnosis. And I would say in many instances, it's consistent. Papillary thyroid cancer is fairly straightforward by most centers. Where we get maybe have a change in review is when we get a second opinion for the Hürthle cell neoplasm, where the people don't know what should we do with this Hürthle cell neoplasm. Do we need to go to surgery? Often, if we just request the slides, we don't even rebiopsy. Sometimes we would rebiopsy that indeterminate nodule. Other times we would just request the slides and wait for our side of pathologists to review those outside slides. And if they re-review the slides as benign or as cancer, then we have a definitive way of treating that. If they say, I agree, this is a follicular neoplasm, then we move forward. Okay. So we have a question that we could pause for, and it says, when should someone seek a second opinion? And they don't completely say for what exactly. Is it for just the thyroid nodule to FNA or not? Or is it a second opinion on the results of the FNA? So Travis, how about when should a patient, if they have a nodule and they've been told, oh, you need biopsy or no, don't need biopsy, what do you think?
I think it's always reasonable to seek a second opinion. If you're uncomfortable with what your endocrinologist or surgeon or family practitioner is telling you, seek a second opinion. There's not really a downside to that. So I'd say do it if you're thinking about it.
And many times, primary care providers may be less experienced in evaluating thyroid nodules. And so, if you're at a center that has endocrinology expertise or has surgical expertise that has a high volume thyroid practice, I think because ultimately what we may be talking about is surgery, and that has important implications, I think it's important to get that expert second opinion for wherever you are in your settings.
Particularly with how the practice has evolved. I think seeing somebody or getting a second opinion by somebody who does a lot of this,
Yes.
they're going to be able to offer that opinion that may change what the recommendation is.
Sure. The other time where that I would perhaps encourage a second opinion, as well as for nodules that are biopsied, and on cytopathology we get follicular neoplasm. I think those. And really, the second opinion is an expert cytopathology review if it's not been done. If you're in a center that has excellent thyroid expertise and expert thyroid cytopathology, then you can proceed accordingly. But if you're in a center that may not have a lot of thyroid expertise on cytology, sometimes you can simply send your slides for a second opinion, or you can go to an endocrinologist at a center that does a lot of cytopathology and say, can these slides be re-reviewed? And that's what we do a lot of at Mayo Clinic. And again, because nationally 30% are called indeterminate, whereas at Mayo only 10% are, many of the ones we see get reclassified.
And that may change the recommendation for surgery, which is a big deal.
Exactly. We didn't talk very much about molecular markers and how the field has evolved for these categories of indeterminate thyroid nodules. So there are, for those indeterminate follicular neoplasms or Hürthle cell neoplasms, there are molecular markers available now, at least 3 or 4 different platforms that are available to try and predict whether these nodules really need to go to surgery, try and enhance which ones should go to surgery because there's a higher risk of cancer, and which ones don't need to go to surgery because they're likely benign. We have some limited experience with some, at least one of these panels that in our practice, because of our pattern of cytopathology, actually wasn't as helpful. We learned because in the end, we have very good cytopathologists, and so we need these molecular markers very seldom in our practice. But there are some molecular markers available that might be appropriate in different practices that might help steer patients more towards or away from surgery. So I think this is a good segue then to begin in the last half of our discussion to talk about thyroid cancer, because this field, as you alluded to, has really changed a lot with the new guidelines from the American Thyroid Association. So when I see patients, and again we're going to focus mostly on those thyroid cancers that are 1 centimeter or larger, that are proven on fine needle aspiration to be either suspicious or positive for thyroid cancer, and what our next steps are. So if it's a patient that I'm seeing at the Mayo Clinic and they've already had their ultrasound at Mayo, they're done in terms of a comprehensive neck ultrasound, because our ultrasounds, when we order an ultrasound at Mayo Clinic, it's a high-resolution ultrasound that includes a very thorough assessment of thyroid nodules and their characteristics, but importantly, it also does lymph node mapping. Without even knowing whether there's cancer there or not, we get a determination of what the lymph node status is.
Right, and it's interpreted by an expert radiologist who is very experienced with looking at things like lymph nodes, thyroid nodules, etc.
Right. So many centers or many other practices outside experienced thyroid practices offer very good ultrasounds for the thyroid, but may not have comprehensive evaluation of the lateral neck of lymph nodes. And this is very important for our surgical planning strategy and to help limit the number of surgeries to ideally 1
That's
for
right.
the patient. So if a patient comes to Mayo Clinic and they've not had their ultrasound at Mayo Clinic, we require that they have a comprehensive ultrasound with us before often seeing the surgeon, or at least before surgery, so we get a lay of the land, so to speak. And this, because we're talking about papillary thyroid cancer, it's important to point out that although, again, and it's important to point out that most patients do very well from thyroid cancer. 90% of patients do very well from their disease, and only 10% do poorly and or have high-risk disease. So we're talking about the majority of garden variety classic papillary thyroid cancers today. So most do well. So and this is a surgical disease, but in order to have a good surgical outcome, both having an experienced surgeon, but knowing a lay of the land with good ultrasound and whether lymph nodes are involved in the central neck, if you can see them, or the lateral neck is very important.
It's exceptionally important for me to understand before an operation what I'm dealing with in regards to the primary thyroid nodule. Are there other thyroid nodules that are present on the same side or the opposite side potentially? And do those have concerning features? Are there concerning looking lymph nodes in the central portion of the neck or potentially the lateral neck? And that certainly influences the type of operation I would perform.
Sure. Now, we've talked a little bit about surgical expertise and why that is important. So, Travis, can you talk to us about the risks of surgery and why then surgical expertise is so important?
Yeah, so in very experienced hands, which certainly at the Mayo Clinic we do a lot of this here, the complication rate is very low. Most of the complications, the important complications, are 1% or less. The most important complication we always discuss with patients is injury to the nerve that controls the voice, so the recurrent laryngeal nerve it's called. Patients have one on each side, and that controls the vocal cord on each side. If that nerve is injured, that can lead to a hoarse voice that's either temporarily hoarse or potentially a permanent injury that causes permanent hoarseness. The risk of a nerve injury is very low. It's about 1 in 200 in experienced hands. Most of the time when there's an injury, it's a temporary injury, so the voice comes back over the course of weeks to months. So that's a very low rate, but it's very significant in that it does have implications with regard to the patient's voice, which is important in many cases.
Sure.
Another risk is bleeding. With any operation, that's an important risk. With this operation, it's exceptionally important because the neck is a very small space. Even a small amount of blood can cause constriction of the windpipe, and that can be a life-threatening emergency. The risk of that, fortunately, is about 1 in 300, so that's a very low risk. And then finally, if we take out the entire thyroid, the parathyroid glands can be affected. Those are 4 small glands, about the size of a lentil, that sit right behind the thyroid. You have 2 on each side. If those are either injured or inadvertently removed during surgery, that can lead to a low calcium level after surgery. As a permanent problem, the risk is less than 1%. As a temporary problem, meaning a slightly low calcium that requires Tums or some other over-the-counter calcium, about 15 to 20%.
So that's pretty significant.
It is.
Can you talk about where the nerve sits, the nerves to the vocal cords? Because patients have read about this and often are concerned about, will the surgery impair their voice? And what makes where those nerves sit in relation to the thyroid, in relation to the surgery, puts them at risk or makes them susceptible?
So first of all, they're very small and can be difficult to identify if you're not experienced in identifying these nerves. And again, there's 1 on each side. And they sort of run right next to the trachea behind the thyroid and behind the parathyroid glands. So when you're mobilizing the thyroid to take it out, you do encounter the nerve and you have to know how to identify it and protect it because the thyroid is in very close proximity to the nerve.
Okay.
The nerve is roughly the size of an angel hair pasta or smaller.
Oh, that's very small.
Very small.
Wow, tiny. Okay. And how routinely, if a patient, one of the symptoms that patients may have with thyroid cancer, most have no symptoms, but some will present, especially if they have had larger tumors, with hoarseness of your voice. So how is that important as you're planning surgery? Right,
that's very important. That's one of the questions we always ask patients when we're evaluating them is, have they had any voice changes? Because a nodule, and particularly a cancer, can potentially grow and invade that nerve that's sitting right next to the thyroid gland, and that can affect the voice preoperatively or before the operation. So if we have any concern for that, either based on voice changes or potentially an ultrasound that shows concerning findings, we would evaluate their voice beforehand with what we call a direct laryngoscopy, which means essentially looking at the vocal cords and determining if they're moving appropriately before the operation. I'll point out we also use a nerve monitor during surgery.
I was going to ask for that. Is there anything you can do, since this is so important? We all need our voice, and it's important for everybody. So what can you do, or are there things you do in the surgery to help limit or reduce the risk to those nerves?
Right. So most importantly is the experienced surgeon, having someone who does a lot of this. And by a lot of this, I'd ask your surgeon, do they do at least 50 thyroidectomies a year? If the answer is no, then the risk may be higher. We do use the nerve monitor, as I mentioned. That's essentially a little probe that allows us to identify nerve tissue. When we touch the probe to the nerve, we get an audible signal and says, yes, this is nerve, or no, it's not nerve.
Okay.
So that can help us identify the nerve.
Is that something that you think routinely used by thyroid surgeons throughout the country?
I would say the majority of thyroid surgeons utilize that nowadays. Not all, though, and not all are experienced with that.
Okay. Okay. And you said a number there, because I always tell patients who are coming for second opinion who maybe can't get surgery at Mayo Clinic, often for insurance reasons or many other different reasons, and they ask me about surgeons at home, and I'm not familiar with them, and I say surgeon with high volume practice. So what's the magic number?
50, I would say, is the magic number. There's a lot of literature looking at volume of practice based on complication rate. And again, if a surgeon does less than 50 a year, I'd look elsewhere.
Okay.
Now, it's interesting. You would think that thyroid cancer is complex. Experienced surgeons are doing all these operations. That's not actually the case. Throughout the country, about half of thyroidectomies are done by low volume surgeons in community practices.
Okay.
And we know the complication rate's higher.
Okay. And, okay, so we've talked about the surgery. We'll come back to how we select patients for the type of surgery, but what's usually the length of stay? What can patients expect if they have a newly diagnosed papillary thyroid cancer and they've been recommended to undergo surgery? What's usually the length of stay in the hospital and the recovery time?
Right, so the operation itself takes about an hour and a half to 3 hours, depending on if we're taking out one lobe or the entire thyroid. The patient usually is in the hospital overnight, although occasionally if we take out half the thyroid, we send the patient home even the same day. And by home, I mean away from the hospital. I prefer them to stay sort of close in the area in case they have any concerns. They can get to me and I can get to them to take care of them. Yeah. But generally the hospital is just overnight. The recovery, usually patients take about a week off of work, depending on what they do. Pain is actually pretty minimal with this operation. Most patients do okay with just Tylenol or ibuprofen. We do offer stronger pain medication if they need that, but most patients have minimal pain.
Okay. Can you talk a little bit about the incision? Patients very much want to know what it's going to look like, and
this is important because it's in an area that potentially would show if you're wearing a low-collared shirt, for instance.
Yeah.
So we like to make the incision low, so when a patient is in neutral position without their neck extended, it's kind of right in the area of the clavicles. It's usually 2 inches or so, depending on the size of the cancer we're removing, occasionally larger. Again, the most important thing is we're able to see the nerve and protect the nerve and the parathyroid glands, and if that mandates a slightly larger incision, that's what we do. Okay. But we do try to keep it as small as possible. We hide it in a skin crease, which is very cosmetically favorable, and a lot of these incisions, you can't even see they're there.
I was going to say, I walk into the room for many patients sometimes, and I can't tell they've had a surgery.
You have to look for them, right?
Yes, I do have to look for them. And so I think patients really like that, and it's important. There are some centers that do different surgical approaches. Can you talk a little bit about that just briefly? Sure.
There are different ways to take out the thyroid. I think you're referring to potentially a robotic transaxillary thyroidectomy, which means taking it out from the armpit, behind the ear, through the mouth, under the lip, for instance. We haven't adopted that approach because really there's not a significant advantage. And there's also a questionable disadvantage with regard to increased complication rate with things like going through the armpit and injuring the nerves that control the arm, for instance. So we have not adopted those alternative approaches here at Mayo.
And I would say in general surgery, which is where you are, we also have Dr. Jan Kasper-Bauer, who has some training in that. And for the right patients with very small thyroid, it may be an option. But it's, again, patient selection has been very key to that.
Sure, and I wouldn't compromise the oncologic or cancer operation for saving the incision size.
Right. So that might be approach, say, if it's a benign lesion for some reason that's small. Okay. So let's talk about our most evolved area today, which is the approach. Do you take out half the lobe? Do you take out the entire lobe and lymph nodes? I would say that up until several years ago, our standard of care has been a near total thyroidectomy. This was for any papillary thyroid cancer, often even if it was less than a centimeter, but up to 5, 6, 7 centimeters. So even 1, 2, or 3 centimeter papillary thyroid cancers, biopsy proven, with or without lymph nodes that look suspicious, our natural or our general approach was a near total thyroidectomy. And the rationale, I think, for that is to decrease the risk of recurrence from the surgeon having to come back and see the patient and taking them back to the OR. But what we've learned over time and appreciated is that for the most part, again, this is a fairly manageable, treatable disease, and that 90% of our patients do very well with 1, 2, 3, 4 centimeter thyroid cancers, even if they have several lymph nodes involved, which now begs the question, do we need to take out the entire thyroid or not? What are the advantages of lobectomy from your
Right.
standpoint? And I can talk from a hormone standpoint as well.
Yeah, so two major advantages. One is the hormone thing, and I'll let you discuss that. The other big advantage is if you're just taking out half of the thyroid, you're not putting the other half of the structures in the neck at risk. So very importantly, we discussed the recurrent laryngeal nerve that controls the voice. If you're not taking out that half of the thyroid, let's say on the left side, you're not putting that left nerve at risk. So the nerve injury rate, particularly both nerves, is cut in half. In addition, if you're not going to operate on that side, you're not going to put those parathyroid glands at risk. So if you're just taking out half of the thyroid, the risk of a low calcium after surgery is essentially zero.
Right.
And so you dramatically reduce the risk of surgery by just taking out half.
Half the lobe.
Yeah.
And so from an endocrine standpoint, where I see patients back post-operatively, when you take out half the lobe, the benefit I tell the patients is it may preserve your thyroid hormone function. And we tell patients that roughly 3 and 4 will have preserved thyroid hormone levels as measured by a TSH 4 to 6 weeks after surgery and may not require thyroid hormone replacement or high doses or full replacement. So that's an advantage. And some patients, because of thyroid cancer, we may put on thyroid hormone replacement to suppress that TSH for the first few years. But many patients may not require thyroid hormone replacement, and that's one advantage, especially when we're talking about those follicular neoplasms that we don't know
Right.
if they're even cancer or not. Secondly, the hypoparathyroidism or low calcium is a big problem in patients. It's very treatable, but it's often difficult to treat. So patients can have calcium levels at very high, very low if all 4 parathyroid glands aren't working. And this requires patients taking very high dose Tums or calcium, plus even prescription level vitamin D.
It's a big deal. It's a low risk, but if it happens, that's a very big deal.
Yes.
And patients think, well, it's easy because I can just take some Tums and we're going to be fine. It's
Yeah.
much more complicated than that.
It is. And so if we can avoid that or limit that risk by first skilled surgeons, even if you have to take the whole thyroid out, but even by our skilled surgeons, occasionally this happens.
It does, yeah.
Taking half the lobe minimizes that risk.
Right.
And when we're talking about thyroid hormone replacement, there's a question that's come through about what's the best thyroid replacement drug after removal of the thyroid for papillary thyroid cancer. And so our standard of care for anybody who is hypothyroid or needs thyroid hormone replacement, whether it's for Hashimoto's, an autoimmune condition, or whether it's because we've done surgery, is levothyroxine or Synthroid. And this is thyroid hormone in the form of T4, which is what the 80% of the normal thyroid produces, and it's given in steady state levels. And so this is our standard of care. I would say that one of the reasons we also recommend lobectomy, and maybe from the question is what thyroid hormone to give, there are many patients who we put on replacement after a near total thyroidectomy with levothyroxine or Synthroid, and we see them back. TSH levels are perfect, but they don't feel so good. Mm-hmm. They have what patients refer to, and we refer to as hypothyroid type symptoms, where they just don't feel well and their thyroid levels are perfect. And these are difficult patients in difficult scenarios because it's difficult from a thyroid hormone standpoint to affect these symptoms. Once the TSH is perfect, it's either not thyroid related or perhaps adjusting thyroid medication and adding a T3 cytomel may be an option, but it's often difficult. Whereas if you can take out half the lobe for a low-risk thyroid cancer and preserve some of your endogenous or your own body's T4, T3 or thyroid hormone secretion, that is really optimal. Mm-hmm. So I think we would say that as we're kind of nearing the end of this of our session, and it's gone by pretty quickly, Travis, mm-hmm. is we really carefully select patients for the type of surgery, whether it's lobectomy or near total thyroidectomy.
We do, and I'll again point out it's a multidisciplinary approach. So it's not just Dr. Ryder or myself deciding, it's all of us together.
Yes, and with the patient preference now in there.
Right.
There are some patients who are adamant they want the whole thyroid removed, and there's some who for other reasons want just half the thyroid removed. Unfortunately, because this is a disease that on long-term surveillance is also very manageable, even if you do develop a recurrence, many options are available to patients where we didn't have that or didn't give that to patients before. Mm-hmm. So I think as we've all become aware of and appreciate that thyroid cancer, while common, is very treatable and most patients do well. We now are evolving into a more appropriate treatment for patients and including patient preference in this. So, after we see patients back after surgery, whether they had a lobectomy or near total thyroidectomy, we reassess their thyroid hormone levels and their tumor marker, if that's appropriate, at about 4 to 6 weeks after surgery. Anything from a surgical standpoint?
As long as the patients are doing well, the incision looks good, and they're not having low calcium symptoms, they generally don't need to come back and see me.
Okay.
Certainly if they have any concerns or issues, then I always see them back.
Okay. So then I or my colleagues or endocrinologists then take over these patients, and I think our role is to keep them away from Travis as much as we can. But thyroid cancer can recur. Papillary thyroid cancer can recur. And most often, if it recurs, it's in the neck, within lymph nodes in the neck. And so many patients we see on a yearly or biannual basis where we do neck exams, thyroid hormone levels, tumor markers, if that's appropriate, and neck ultrasounds. And this will identify the majority of recurrences. And if we do get a recurrence, then sometimes we can get Travis involved, our surgeons, for reoperation. That's been the standard of care. But we also have here alcohol ablation that was really developed by Dr. Hay and Dr. Bob Lee and Dr. Redding here at Mayo many years ago, where we can, if a tiny little lymph node has come back, and it's only 1 or 2, in a patient who has been heavily operated on in the past, we can inject that with a little bit of alcohol and avoid surgery.
And that's a big advantage in select patients because surgery can be difficult in reoperative cases. So the nice part about being here is you have multiple options. And again, this multidisciplinary approach where you have experts in surgery, experts in ethanol ablation or injection of alcohol into these nodules, and we can together with the patient decide what the best and safest approach is.
Sure. So we have just a couple minutes left, and questions may come through. In the meantime, we can talk about anything else you want to emphasize about our practice and our approach, Travis?
Those are the major things.
Yeah. So we do have, there are some nodules that are cystic, that are not cancer, but they cause either cosmetic reasons because they're big lumpy bumps in the neck, and people may not like that visually. Sometimes we can see they can cause compressive symptoms, even though they're not cancer. And so sometimes we operate on these. Or sometimes we can, with our interventional radiologist, pull out some of that fluid, inject back alcohol, and that shrinks it and controls it. So again, it's nice now, as we've evolved our practice, to have both operative and non-operative, less invasive approaches for patients with thyroid nodules.
That's right. And I guess one thing I would want to point out is the speed at which things happen here. And I think that's very important. Patients come here from far away oftentimes, and they can get things done very rapidly. They'll see the endocrinologist, have their ultrasound, the biopsy, see the surgeon, all sort of in the same day or 2 days, have their operation potentially the next day, and then fly out a day or 2 later.
Yeah, I wasn't sure I believed that when I joined here, when I was recruited for Memorial 4 years ago, and I was told that you could get your ultrasound, biopsy, and surgery within the same week. Was impressive, and it can happen.
That's very unique.
Yeah. So. Well, great. Well, thank you, Travis, for joining me today and for this Facebook Live session. I know there's maybe questions that we didn't get to every question, but we'll certainly go through those after this session. And, of course, we're happy to answer those questions that we didn't get to as we move forward.